In the name of the Almighty, who is merciful and beneficial. We have previously reported 12 plain X-ray tests, and we have interpreted it in our fashion. Today, now there is a slight modification in my presentation, because some of the students who are appearing in the fellowship examination and the other foreign examination, they told me that you are, although have given knowledge previously in the different sessions, almost 12-hour sessions, so there is no need of actually to repeat it so much. It's all quite fine. So I have very briefly described the interpretation. Now the X-ray test number 30. Age 38 years, gender female, complaining of the fever, intermittent fever, often, and dry cough, 6 months. On examination temperature at the time of presentation was 100 degree Fahrenheit. The pulse was 100 per minute. Blood pressure is 126 by 80. Now nasal congestion was congested with the post-nasal drip. Omohyoid group of lymph nodes, which is the cervical group of lymph nodes, anatomically speaking, omohyoid nodes, they are bilaterally palpable. They are about 2 to 3 centimeters. About 2 centimeters is usually normally taken. It is more than that. It is 2.5 or 3. They were shorty in palpation, as well as their palpatory characteristics is concerned, and they were non-tender. The investigations: hemoglobin 11 gram %, total leukocyte count 7,900, ESR 65 millimeter per first hour, random blood sugar 175, urine RE proteinuria was present, significant proteinuria. Electrocardiogram showing the first degree heart block, AV block. It was AV block. X-ray chest now is presented to you for further interpretation. Now, interpretation of the X-ray number 13. It is just POV. To see this X-ray very carefully, I will give you 30 seconds to see it properly and try to find the positive heart data in this X-ray. Positive heart data in this X-ray. Although you know how to report it, I have done much time, I have spent much time on interpretation on the routine radiography is concerned. What is seen by all? The eyes are the same, but the results can be different. Take your time and try to find any abnormality in this X-ray. Any abnormality. From requirements till down to the lymph nodes and the diaphragm, etc. What is your way of interpretation or presentation? Now this is the X-ray test PA view. You see that all requirements will relent. The abnormality which is shown here is this, that the lung fields on this side and this side look it slightly hazy. This is the breast shadow lower border, Therefore, 1/3 of the hemithorax or hemithorax will be neglected, anything, haziness. Other than that, it is abnormal. And here also, there is haziness, and in this X-ray, and the bronchovascular markings are protruding out from here, and is touching the lateral 1/3 of the wall of the thorax. The second finding is positive finding in this X-ray is look the lymph nodes. Lymph nodes, this and this left hilar lymph nodes and the right hilar lymph nodes. Now this is the part where the paratracheal group of lymph nodes can be observed. Now this is the part. They are not significant enlargement is seen in this, as well as the hilar is what is called as a carinal or subcarinal group of lymph nodes are here in this area. They are not visualized. Only these perihilar lymph nodes are seen in this X-ray. Size is about 2.5 centimeter 3, 2.5 centimeter to 3 maximum should be taken, and they are both sides. Because of this, you can see they are enlarged hilar and they are prominent hilar. So this is the X-ray in which the bilateral prominent and hilar enlargement is seen at the perihilar area. Make your differential diagnosis by yourself. Another finding is here is the tenting is seen here in this part. Whatever the disease is in your mind, with the help of the data, you must justify it then, or other investigation are needed should be mentioned. What they want, the people want that the direct diagnosis, what you have done. The art of clinical medicine is differential diagnosis. The differential diagnosis is of the bilateral lymphadenopathy is wide, consists of the many infections in big groups, acute inflammation or chronic inflammation, or the tumor and the tumor-like states, some of the immunological conditions, some of the conditions which are associated with pneumoconiosis and autoimmune diseases and the parasitic infestations, the lymphoproliferative disorders, the myeloproliferative disorders. So a long list can be made, but what is seen is this, tapering the diagnosis to one, is that there is very symmetrical type of the shadowing is seen. Symmetrical bilateral perihilar lymphadenopathy is seen in very few cases, and one is sarcoidosis. Radiologically, stage 1, 2, 3, and 4, or 4 plus. These were the stages. You can go to your book and learn it, because of the thing they have actually requested me to be very precise. So I have done like this. This is the hard data in this X-ray, and if you compare with the clinical data, the fever and cervical upper groups are also involved, etc., then you can make diagnosis well and can be confirmed by the other tests which are helpful. In my last part of this discussion that I will say that this is the sarcoidosis is one disease in which is the diagnosis of exclusion. Number one. Number two, it is one of the commonest cause of the dry cough, chronic dry cough in most part of the world. This is the chest number 14, X-ray chest number 14, this is the last one. The case is that the age is 65 years in this patient, smoker since 40 years, gender male, working in the textile industry, complaining of effort intolerance, the loss of the weight during the 3 months, significant weight loss. Recently noted brown colored sputum. To us, it is hemoptysis. On examination, the temperature was 99.8. It is low grade. Pulse is 110 per minute. Blood pressure was 100/65. Anemia was positive. Finger and toes, they are clubbed. They are grade 4 clubbing with tenderness, and liver was 3 centimeters palpable. Now, respiratory system examination was done on inspection, asymmetrical chest, recession of the chest for right upper chest, and there is decreased movement on this part. Now, palpation, trachea shifted to the right side, tactile vocal parameters also obsolete in some part of the world, not all, reduced in the right upper chest, percussion notes dull in this area, from the supraclavicular fossa till third intercostal space. Auscultation, breath sounds are absent in this case, no breath sounds, and the vocal resonance reduced at the same area. Now, investigation has hemoglobin 7.8, TLC 5,500, platelets was 3,20,000, ESR was 80 millimeter, random blood sugar 166, urine RV was normal, and his X-ray test was done and presented to you for the interpretation. Now see this X-ray for 30 seconds and see what are the interrelated positive findings as per data is given to you. Very cautiously see this X-ray. So, what are the positive findings in this X-ray? Requirements, etc. Everything should be included. Anything abnormal, just point it out. To me, the eyes are the same for all. If you are visualizing, I am also visualizing in the same fashion. What is seen is seen. The thing is here, first of all, this is the trachea, which is definitely deviated, because this is the sternal angle, and this is deviated toward the right side. It is about 25 to 30 degree deviation. This is positive finding in this X-ray. What the examination revealed now here, this is the part where the examination was done and the positive findings were written previously. This is the part. This part is hazy, and this is here the fissure, which is the transverse fissure, seen very clearly in this X-ray. Okay. The dome is very, very, it is very, very globular. Look the curve of this. And this haziness, it is non-homogeneous reduced opacity. Some of the broncho, what is called the gram pattern, is seen in this part. And the other thing is there is a relative hyperplasia is seen, because this is masked here, the hyla on the other side. These are the perihyalar group of lymph nodes. The bronchovascular markings here, they are going and downwards in a bunch, and there is slight more hypertranslucency in this area is seen. Now this is the non-homogeneous radiopacity, and it is non-reticulated type of opacity. Some of the what is called the bronchoaerogram pattern type of the opacity with the transfer curve, it should lie in the transfer fashion. It is curved just like this. Superior convexity is seen. It should be like this. Now here it is this. Trachea is deviated on this side. Now making these are the positive findings. Other than that, the middle mediastinum, the upper part of the middle mediastinum, and other parameters of the X-rays doesn't seem to be abnormal, anything else which is abnormal. So differential diagnosis will be made here, whether it is the stage of the red hepatization or the gray hepatization, rather, of the acute inflammation, the lobar pneumonia, resolving now. If it is resolving pneumonia, then white trachea is shifted. Okay. Secondly, the chronic inflammation, if it is a chronic inflammation for the tuberculosis, for example, or a fungal infection causing the fibrosis and is pulling the trachea to the same side, then there should be reticulation. It should be reticulated opacity, not the pattern which is seen here, bronchoaerogram pattern. No. And the fissure should be normally placed at its place, transverse fissure. And oblique fissure is here. Transverse fissure is very prominent, and it is convexity upwards. Now, third part of the malignancy or the tumor-like condition can cause it. If the main bronchus is obstructed, main bronchus means that there is a right principal bronchus, there is a left principal bronchus. The right principal bronchus is divided into three lobar bronchi. Lobar bronchus or principal bronchus is obstructed by anything, by mucus or by any severe inflammation or aggregation of the cells, or if it is pressed by outside, etc. Then this is definitely blocked completely. No very small amount of air will pass. If it is this is the condition, it means that the distal portion of the supplied area, there is less air inside, the opacity and haziness are seen much. So this is the justification of the collapse of the lung. The lung is collapsed because here is something is going on here, which is obstructing the principal bronchus. Rather, it is the right lobar bronchus which is gone. The whole part is affected. The right lobar bronchus, where the blockage occurs, the collapse here. There are two types of the signs of the collapse. One are called the direct signs. One are called the indirect signs. Indirect sign is the trachea shifting, mediastinal shifting. The dome of the diaphragm should be seen for it, whether it is downwards, going downwards more than normal or upwards. So rise of the dome of the diaphragm or it is the fall of the dome of the diaphragm. These are indirect evidences. The direct evidences are the displacement of the fissure. This is very, very important. And secondly, the type you see here is non-reticulated type of the opacity with a bronchoaerogram pattern. So this is the part which is collapsed because trachea is shifted to the same side. Acute inflammation will not cause any tracheal shifting. The chronic inflammation will pull the trachea to the same side with the reticulated appearance. So my justification is that it is the right upper lobe collapse because of anything. You can investigate further whether it is because the data was available previously. More likely it is the bronchogenic carcinoma which is blocking this. You confirm it by other investigations and manage accordingly after clinical staging. I think that this is my brief, rather, it is more than brief terminology. I do not remember what is called as. For me, I hope that this type of presentation which I have given probably suits you for the fellowship examination or the foreign examinations. The positive finding and justifications of my diagnosis or differential diagnosis. Inshallah ta'ala, I am planning that all X-rays which are of the interest of the students who are appearing in the examination will be done in one setting, means that on the first day I will give you the X-rays, about 40 X-rays or 50 X-rays. Take your time and try to diagnose. I will not do anything. The second part will be the answers given and match your diagnosis, whether you have done correctly or wrong, and then correct it accordingly. In this fashion we can do and can summarize the whole of the chest X-ray, plain X-ray chest radiology. For my side, I hope that you can be benefited like this. Okay, thank you for a good listening. You are a good listener. I hope you have enjoyed this presentation. From my side, goodbye. May Almighty saves you from all evils.